A little bit about what we do here at Cellmyx, specifically regarding our new kit for closed system fat transfer and orthopedics and pain management, specifically on this talk, as well as aesthetics. So we'll get into what we do. So we like to try to provide the best information possible with what's available in the market regarding fat grafting. It's something that we've specialized in for over 10 years. So myself, my colleagues, our engineers and scientists, we try to pull this information together so that we can help better the industry. Working with doctors like Paul Tortland on the orthopedic side or Brian Kinney on the plastic surgery side, we're able to design and develop these products that are not only effective, but that are safe and cost effective as well. So we want to try to provide the best information possible in regards to the products that we provide and the information and technology that we put into them. So our focus really, like I mentioned, is all around fat. So we do follow what's the guidance within the FDA, that is the Public Health and Service Act, Section 361 to be specific. And within the FDA code, that's 21 CFR 1271. So we register all of our products with the FDA. They come in and audit us every year or every other year, depending upon how busy they are. And we have a very good quality control, quality assurance program in place to assure that all of our products are up to guidance and are recorded appropriately for their safety and efficacy. So our products include intelliFat, which we're going to be discussing here today. It's a single-use disposable kit. We have other kits or devices that are used within harvesting and transferring fat as well, Aquacell and lipo-loop, which are more for large volume fat transfer and harvesting of fat in a viable method that are used by a lot of plastic and cosmetic surgeries in the US, Europe, and Japan. So getting into a little bit about fat and why we use fat in practice in orthopedics, pain management, and other specialties is because back in 2002, in the discovery of stem cells within fat, they discovered that there's a huge regenerative capacity within the fat, that these cells are stored within our fat, that it can easily migrate up to the skin for a burn or down to the muscle for a tear. So when Dr. Yoshimura, who's a plastic surgeon out of Japan, started doing some histology and looking at what makes up fat, even though the adipocytes make up only 16% of the actual cells, they take up over 80 to 90% of the actual volume of fat. But the rest of those cells are the supporting structure or cells of the fat. And these are the stromal and vascular cells that lie the arterial and venous wall, which include epithelial cells, fibroblasts, smooth muscles, and of course, some of the immune cells that are present within all tissues will make up close to around 10%. And so looking a little bit at the arterial and venous anatomy here, in these diagrams, you can see that from the lumen all the way down to where the adipose, there's in the vascular niche there is a lot of different cells that come into play in regarding to what's happening locally and systemically. And all of these cells play a vital role in wound healing, repair, and of course in fat metabolism. So looking at the H&E and stain on the left, you can see that's a vein there. You can see how there's a lot of cells that are condensely packed in and around the vein, but as you spread out into the adipose, these cells become fewer and far between, where you don't see quite as many nucleated cells present because the adipocytes can take up so much of the volume. And looking at some of these markers, this is using fluorescence in situ hybridization. You can see some of the different markers that we're using here in order to identify some of the stem and regenerative cells that lie around these arterial and venous walls. CD146 is a great marker looking at a parasite. CD90 is more, it can be, and CD73 can be found on these type of MSCs as well. Not necessarily parasites, but endothelial progenitors. And other progenitor cell types like fibroblast progenitors that lie in and around this area that help with forming new arteries, veins, and repair and replacement of soft tissue. And so in looking at using fat, bone marrow, at least within orthopedics, bone marrow was thought to be the go-to tissue that you can easily harvest and pull regenerative or stem cells out of. Well, and looking at some of the statistics and numbers that are in publications over the years, it's been proven now that fat actually retains a lot more stem cells, or regenerative cells, I should say, throughout the lifespan of a person than bone marrow. Whereas a newborn, per 1 million cells, only about 600 will be an actual stem cell, falling all the way to 3 by the time you're 80 on average. Of course, that varies by patient to patient. But in your adipose, you can have as much as 200,000. By the time you get down to 80, you'll still have at least about 5,000. Of course, again, this varies with age, genetics, harvest location. They may be a factor as well. So, but all in all, it just shows that the regenerative capacity of fat as you age can be a little bit stronger than that of bone marrow. And here are some of the advantages of using adipose for some of these soft tissue repair and replacement type of procedures that we've been mentioning. So your adipose will have, on average, again, this can vary, about 6 million cells per cc, of which 50 to 80% of them will be a stromal or vascular cell. And that's taken from various sources. Obviously, when I said with Yoshimura, noted about 16%, that's the mean average. It can be higher or lower depending upon BMI and the patient. So if you extrapolate all of this information based upon what Fraser published, Pittenger published, you can gauge in between 5,000 to 200,000 adipose-derived stem or regenerative cells per milliliter adipose. Taking that to bone marrow, you're looking at, again, about 5 to 6 million nucleated cells per milliliter, very similar to fat, but the percentages drop dramatically. You're looking at 0.001 to 0.01% of these being stem or progenitor cells, which equal to about 60 to 600 per ml. So there's a drastic difference between the two different cells. Now, there's a difference between numbers and, of course, pure efficacy, or the proliferation and differentiation of these different cell lines. Bone marrow has been shown to produce chondrocytes a little bit better than adipose, but adipose seems to grow and produce a broader spectrum of different regenerative type of cells that are found within soft tissue. So it's still under discussion of whether or not when to use different these different autologous cell products. I'm under the belief, from what I've heard in the industry and what I've read, that if the patient's younger, yes, bone marrow is still a very good option. But as you age, adipose may become a better option that can get more continuous results than bone marrow. And when I speak to some doctors every once in a while, and they will sometimes mention that PRP is a regenerative or stem cell product. It's really not. It's more of a growth factor product that helps recruit cells to the region. You're not actually deploying cells that can actually help in the repair and placement of this damaged tissue and take up a new home, where depending upon where you're transferring it. PRP is an enabler, which signals to the local cells to wake up and start regenerating and repairing, and it really doesn't, you don't have a lot of stem or regenerative cells circulating within you. It's more of a differentiated or adult cell product that, like I mentioned, helps recruit the cells to the local region to help enable repair and replacement. And according to Dufresne, publication in 2017, that's the impact of age of human adipose stem cells in bone and tissue engineering. He mentions all these great advantages that adipose has over bone marrow, and he is a big bone marrow guy from his past publications. And so, getting into how we can make this all work with fat. A lot of plastic surgeons back in the 80s and 90s used to think that all you have to do is just pull the fat out, transfer it back within a short period of time, and it would just stick and survive. Well, that's not always the case, and that's not what they saw in surgery, actually. So there's a lot of things, because adipose is a very fragile cell, one of the most fragile cells in the body. In order to get good results with it, you got to pay attention to all the weak links that can happen, and which can lead to your fat graft not surviving, or you're not getting the results you're looking for in using fat for regenerative purposes. So I say the protocol does matter. Obviously, you start with the liposuction modality. Lasers and ultrasounds, anything with heat is definitely going to lyse or damage the cells. anything over 42 degrees centigrade will denature proteins, and that can, of course, kill or damage the cell and send it into apoptosis. And your tumescent fluid that you use, got to remember that lidocaine is acidic. It's meant for long-term stability of lidocaine and needs to be in an acidity of in between 4 and 5. So even putting in 50 mLs of that into a 1 liter bag can drop the pH down below 6, believe it or not. So this is why you need sodium bicarbonate. Makes it much more comfortable for the awake patient and much more comfortable for the cells. And so lactated ringers does not buffer pH in the solution. Lactated ringers, lactate is turned and metabolized into bicarbonate in the liver. It's meant to treat acidosis. It's not meant to help keep the cells at a balanced pH before you transfer. So be aware of that. Harvesting cannula is important too. You want to avoid cannulas that have rasp or sharp edges. This can cause trauma to the fat, trauma to the cells, make it very uncomfortable for an awake patient. You should only use these type of aggressive cannulas in a general, not a local anesthesia case. And this can also harvest the type of tissue which is more dense connective tissue from septae that can block your fine needles or microfacial cannulas. So in intelliFat, we try to, in our fat grafting cannulas, we try to have appropriate cannulas that lead to a decrease in blockages. Negative pressure is very important to pay attention when we're harvesting fat for transfer. Large volume within plastic surgery, we try to keep it at or above 0.4 atmospheres, which is about 405 millibars of mercury, or about 12 inches of mercury. So when you cock back a syringe to 10 cc's, that creates right around 0.4 atmospheres. If you can't crank it back any further than that, you're going to get too much negative pressure, and you can actually damage the cells that you're initially harvesting because of that negative pressure. The next step is when it comes to gravity separation, decanting the infranatant, because the fat will float if you harvest it the right way. Getting rid of this infranatant, you don't need a centrifuge or anything. It's easier just to use filters or gravity in order to get rid of this fluid. Centrifugation can lead to a too dense a fat graft where you don't have any fluid for the cells to survive before nutrient diffusion can happen. I'd like to try to have a little bit of water when it comes to grafting because it makes it easier for it to flow in and out of needles or smaller lumens like in syringes. So having about 20 to 30% saline is actually a good thing to have. You don't want centrifuge fat, even though it looks better when you initially transfer it. It can have some negative effects when it comes to the results you're looking to get. And you want to try to transfer these cells fast. Within 4 hours, your fat starts to die once outside of the body. It's not as robust as some of the stromal and vascular cells that are within the fat, which can live up to 24 hours outside the body at room temperature. So, in getting into the size of adipose graft, when I mentioned nutrient diffusion before, size really does matter. And Dr. Yoshimura again did some great research in looking at what makes a fat graft survive. And because angiogenesis takes so long to happen, we want to try to get smaller fat clusters. This is about 2 millimeter or less in diameter. The first 300 micrometers going into a fat graft he called the surviving zone. This is where all cells can basically survive. Any deeper than that, most of the adipocytes won't survive, but the stromal and vascular cells will. And anything beyond that, he considers the necrotic zone, or this is the zone in which the cells can't get enough oxygen and nutrients in order to survive until new blood vessel formation happens, and the inside becomes necrotic. And this is right around the 2 millimeter to 2.5 millimeter diameter max. So a lot of our fat grafting or fat collection cannulas will have apertures of 2 to 2.5 millimeters or less to assure that all the cells can survive for grafting, whether that's in orthopedics or in plastics. So I asked a lot of physicians who may have been doing this a while, do you really know what's in your fat? Or you just been pulling the fat how you have been for 20 years and just transferring it and saying it works. So in looking at these different techniques and methods in which you harvest, process, and transfer fat, we discovered that some things do work and some things don't work. Obviously, a lot can be said about the physician's technique in which he transfers and the patient's ability to keep that fat that's been transferred to take when it comes to plastics, or for it just to work from a regenerative standpoint. But we try to at least check all the boxes when it comes to providing a high viable fat graft in clinic for transfer. So using some of these techniques with different harvesters or higher negative pressure, as well as some of the positive pressure, which I'll talk about in a little bit, that can lead to cell death. We try to make sure that your fat graft looks like this, no lipid release, not much of an oil layer, and you've got a nice viable product that can transfer and have the best chance of survival. So this is why we created intelliFat. We took everything that we learned from the plastics over the years in parts and cannulas and other things in which on a reusable level, and we put it in into this kit, which is small, compact, for small volume fat transfer. So you don't need large canisters, you don't need a big aspiration pump or infusion pump, and even our AquaCell device, even though it's small, it's still larger than what you do when you're just harvesting via syringe. So this is all for in-office use, although a doctor, of course, if you wanted to use it in surgery, which I've heard several doing, can use this kit. So this is the aesthetic kit you're looking at. You can see the transfer cannulas here in the kit in which Dr. Tortland will be talking about. There'll be some components that are missing that are simply focused on the regenerative aspects. So we have two different types of harvesting cannula here. Both can be used to infiltrate tumescent fluid. One is for millifat and one is for microfat. Transfer cannulas, one's an 18 gauge by 5 centimeter, one's a 19 gauge, excuse me, the other's an 18 by 12, so you can reach finer areas around the eyes and face, or even this cannula can be used for hands or other areas. We have our resizers and filters here, which we'll get into in a little bit. Stromal stamp is nice. A lot of physicians like that to stamp the stromal vascular tissue and adipose-derived regenerative cells into the face. Then we have just luer-to-luer transfers, and then some caps for your convenience as well. And so here's a video in which we explain use of the kit within a pain management practice. You can see here we're demonstrating a soccer player hurting the knee. Physician discussing the kit with their patient. First, attaching a infiltration cannula and filling it and putting it into the patient. Wait for 10 minutes, preferably 15, but minimally 10. And we'll attach the aspiration syringe. Doctor will cock that to 10 cc's, 0.4 atmospheres at a time. And then once it gets close to full, you keep on going every 10 cc's. Or less, you can crank it 5 if you want. Some doctors prefer to just take their time and go 5 at a time instead of 10. It's completely up to you, but pulling any more than 10 cc's, you can, by the science, damage cells. And we attach the millifilter to press out and keep all the structural tissue within the syringe. Attach a luer-to-luer. And this is just sterile saline. We're going to give the fat a little wash. And this will all be demonstrated live in Dr. Tortland's talk here in a little bit. Push off the waste then again. And we're going to transfer to a 10 cc syringe. So we want to try to use less pressure. Smaller cannulas create less pressure, and then we're going to micronize the tissue here, turning it into what we call stromal vascular tissue, which is components of 200 to 500 micron sized particles of viable adipose. Then he's transferring into a syringe for transfer. And hopefully he gets a good result and he's back to playing pain-free. So stromal vascular tissue, it's a term that we came up with last year to best describe our product basically, and some of the other products that are out there. A lot, not to bash the nanofat term, but nanofat is something that you couldn't see with the naked eye or even with a microscope. And the fat is not present within nanofat. It's all you have left is the stromal and vascular components. More accurately, you would describe that as what Lipogems uses as micro-fragmented fat, which is what SVT is in some senses, but we feel that it's a bit denser because you're not relying upon as many adipocytes being present in order to make the fat float to get your final product. So it's actually more dense, and it won't gravity separate at the end of the day compared to what the fat they initially harvested, because a lot of the adipocytes during the micronization will get a little damaged and may release lipids. And these microstructural components will, because they're not being held on to by adipocytes holding on to lipids, they won't rise to the top as easily, which is why we have the filters present. So it's considered minimally manipulated, so because it's still structural in nature, it's not a single cell suspension. And we feel that it's superior to nanofat, which is for plastics and orthopedics. Also, the advantage of it is that compared to like stromal vascular fraction, where you have to digest the cells out, you can get more cells per capita because all of the cells are still within the vascular niche, and you're not having to pull the cells off or pulling the apples off the tree or pulling the grapes off the vine. They're all still present within the vascular niche, even though there's some argument in which are they still able to get out of the arterial and venous microenvironment to do their job well. We're seeing the cases even with lipogems and with ours and other type of adipose cell products that yes, it's still getting results. The cells are still alive. They grow in tissue culture rather well. And we have seen that SVT and other microfragmented fat products do grow better in tissue culture because initially with the CFU-F growth curve is more dramatic. These cells grow quicker in tissue culture because they're surrounded by other cells than a single cell suspension like SVF. So the SVT processing is simple. We harvest 1 millimeter size adipose clusters. We wash like we showed in the video. We use the resizer. We then can wash again if we choose to, depending upon what the doctor feels like doing. You can then wash again using the microfilter. Then the final product you can get through a 25 to even a 27 gauge needle, though I recommend 25 or greater, 22, 23. Well, I'll talk about in a little bit. Positive pressure, just like negative pressure, can be the enemy of cells as well. And on the right here, you can see the diagram what the final fat graft product looks like. Here's what the resizer looks like on the inside. It's got sharp edges, so when you're cutting these 1 millimeter size adipose clusters, you're not creating a ton of pressure as if you would a wire mesh or a perforated stainless steel disc like some other products that are out there that help micronize or resize adipose. So less pressure, the better, and it allows for a really clean cut. So when it comes to the colony forming unit, when we validated this product compared to a control and some other products in which we're in development and our competition, it grew very well compared to SVF, and this was one of our other prototypes and products and some other competition out there in which didn't grow well at all, and so we won't name these products. But all in all, this is after developing and working on trying to find the best way in which we can micronize fat under less trauma. We discovered that our design was working really well, and we went into production after this. So when I talked about negative pressure can be the enemy, and I went over those things as well. Positive pressure can be too. When you think about the force that's applied from a syringe and through a hub, which is typically 2 millimeters, down and through something that's even less than 2 millimeters, the larger clusters and or if you get septae, like I mentioned, if you're harvesting with the wrong cannula, can all lead to that positive pressure or breakage and cloggage. So the cluster diameter is important. So is the viscosity. Like I said, centrifuge fat is very hard to inject. If you don't have a little bit of saline there, it's going to be difficult to push through smaller lumens, 18 gauge and less. So you want to have a saline component within there. And as well as the lumen diameter of the syringe, as I mentioned, 2 millimeters, but smaller syringes are easier to inject than larger. So this is why a lot of physicians in orthopedics and pain management both typically use 1 to 3 cc syringes for injection. They never use anything larger unless you're doing large volume fat transfer, which is a whole nother subject matter. So here's some more validation information regarding some of the controls. We used for this the tulip nano-fat on the same patient. Took the same fat through the same process, harvested the same way. One just went through the nano-fat process. One went through our the process that led to the creation of the diamond cut resizer, micronizer. As you can see, there's a lot of lipids that are present here between the black and white images, where the black and the white will show more lipids. As you can see, all right through here, and these large circles here, as well as here and here. So with our what we were calling the micro MMT at the time, we have much less. We do have some lipid component here, but we estimate that the lipid component is a quarter to even 1/5 the amount that what we saw in the tulip nano-fat. Even though we do have some lipids, a lot of the cells are still intact. Adipocytes are viable and present, even though you can start seeing them pop actually under the microscope after about 30 minutes or so. But this all, like I said, we put some science to this so that, and it showed when we did the viability from the average of 17%, and we saw an average of 54% within this study here. And so lipogems is probably one of our biggest competitors. It's a good product for fat grafting. I won't deny that. It's expensive. It's a little bit cumbersome to use, but they do get quality microstructural fat. But their final product relies upon having a higher specific gravity for the fat to float. So they have to have a lot of adipocytes present that you can see here within this fat graft for it to float to the top when they harvest it off the top of their syringe. When we harvest our fat and then take it through our micronization process, everything stays within the syringe. And so with the millifilter and the microfilter, we're not losing any of these cells or components that if they don't have lipids, adipocytes holding on to them, they won't sink or fall to the bottom or get thrown into the waste. They're all still there and present. So we feel that, and we need to prove this, obviously, that our final product is a little bit more cell rich, that will have more cells per cc because of the difference in these two different processes. Now what I'm showing here is this is a lipogems image here on the bottom. This is about a 500 micron size fat cluster. The adipocyte is anywhere from 100 to 40 microns in diameter. And this is our one of our patented micro-G cannulas. These are in an array of 300 holes that are 500 microns in size that can harvest this size clusters directly. Again, a little bit more conducive for fat grafting than for regenerative purposes, where we're trying to get stromal vascular fraction, have more of that micronized connective tissue, more of the arterial and venous components that have more of the regenerative cells present. But this just shows that we can get a very similar product without having to take it through a lot of unnecessary steps, as well as paying so much money in order to get that product. And so in review, when it comes to intelliFat, we've really streamlined the process to where we can get it down to about a procedure done in 30 to 45 minutes in the orthopedic and pain arena. When it comes to if you're doing hair restoration or fat transfer to the face, obviously it can take more time, and that's very patient and physician driven. We've cut out centrifugation compared to a lot of other products out there, and we only have filtration. This will save you time and money, obviously. And if for those who are still using stromal vascular fraction out there, we don't have any enzymes. We've proven that we still have a high amount of regenerative cells per capita, so you don't have to digest the cells out. You don't need any capital equipment, so this will also save you time and money. And we do feel that according to the publications out there, it has a higher regenerative potential according to the CFU data, the NanoFat and other emulsified and centrifuge methods. It's because you have more parasites and MSCs within the vascular niche and less adipocytes than some of those products in which I talked about previously. So the intelliFat mechanical resizing and filtering is compliant, as I mentioned earlier, with 21 CFR 1271, and is, like I said, registered with the FDA and meets minimal manipulation criteria. Here's some of the supporting publications that you guys can look up at your leisure, and which I mentioned. And without further ado, I'd like to introduce you to one of our chief medical advisors in the orthopedic and pain space, Dr. Paul Tortland.
Thank you very much, David, for that introduction. I really appreciate it. For my portion of the talk, we're going to be talking about the clinical applications of the SVT, more for musculoskeletal and orthopedics and regenerative medicine purposes within the musculoskeletal and orthopedic world. A little bit of background about me. I've been in practice since 1995. I'm fellowship trained in primary care sports medicine, so I'm not a surgeon. I've been doing regenerative medicine for over 26 years. I originally started with prolotherapy, and in 2007, I became the first physician in all of New England to begin using PRP. That quickly transitioned in 2008 to doing bone marrow-derived stem cells, and then the next year in 2009 to fat-derived stem cell treatments. I'm also a nationally recognized expert and teacher in both regenerative medicine and musculoskeletal ultrasound. I teach a number of courses around the country on ultrasound diagnostics and ultrasound intervention. Over the years, I've had the opportunity to try many of the commercial systems out there, both PRP and Adipose. And I ended up falling into the intelliFat, mainly because I was using the Aquacell, which was a system that David had mentioned previously. I was very frustrated with a lot of the other commercial systems out there, both in terms of the complexity and cumbersome nature of their use, as well as the cost. And also, I was not very happy with the final product that these other systems were generating. So when I started to work with Millennium and Cellmyx in helping them to develop the intelliFat system, I saw right off the bat that they really seemed to be hitting a home run with this. You can see down at this the bottom here that I think intelliFat, based on my experience, is the easiest to use. It has the shortest processing time, and therefore that means your procedure time is cut way down, allowing you to see more patients. The final product is much more easily injectable, and I routinely inject through a 21 or a 25 gauge needle. And in my experience, I think the final product is really superlative in terms of its regenerative capacity. Some of the things we're going to be looking at in the time that I have left is, how do you choose which patients are candidates for this? Obviously, consent. What are some treatment protocols? What are some of the supplies that you would need besides the intelliFat kit? What is a smooth workflow? Things proceed smoothly and efficiently. And then what's your setup? So for patient selection, as David pointed out, as we age, the number of regenerative cells in the bone marrow really falls off, not in a linear fashion, but really in a logarithmic fashion. And that does not happen to anywhere near the same degree with adipose. Therefore, for anyone over 60, and especially anyone over 65 or 70, if I'm going to be performing a regenerative medicine treatment, I'm thinking in terms of stem cell use, adipose as opposed to bone marrow. I'm not saying bone marrow doesn't work, and I know there are a lot of people who use it, but I think that the adipose works better. In fact, we did a 6-month trial in our office where we stopped using adipose altogether, and we did only bone marrow for the 6 months. And it was uniformly conclusive in our office that we did not see as good a result as when we were using the adipose. So now we largely use the adipose for the conditions that we'll talk about. In terms of pathology, I really think the SVT that the intelliFat produces is outstanding for grade 3 and grade 4 osteoarthritis. If they have more mild arthritis, such as a grade 1 or grade 2, I think the literature really supports that PRP is generally more adequate and more cost effective in most cases. Now, that doesn't mean you can't use fat, you certainly can, but when I'm trying to determine what is going to be the most cost effective care, I tend to reserve the adipose for the more advanced cases because I need a bigger gun. I need a more aggressive treatment. I've also found that using PRP and bone marrow, which is largely a liquid product, tends not to stay in meniscal and labral tears very well, and I don't get very good results using these products. The SVT that you get from the intelliFat, however, has a connective tissue matrix. There's almost like a putty component to it, and so it tends to stay where you put it. It really adheres to the tissues much better. So I really like the intelliFat SVT when I'm treating meniscal tears and labral tears, whether those labral tears are in the shoulder or in the hip. Also, when we've treated larger tears in tendons, such as rotator cuff, oftentimes, especially in the rotator cuff, these tears will communicate either directly with the joint space or with the bursa. And we have found that when we inject a liquid product, such as PRP or bone marrow, we see it under ultrasound go into the tear, and then it leaks right out. It will either dump into the joint or into the overlying bursa. So you almost have wasted your treatment. When you use the SVT, on the other hand, because it has a connective tissue component, it stays where you put it. So when you put it into these tears, it will stay there and not tend to leak into the joint or the bursa or the surrounding tissue. In terms of patient selection regarding body habitus, obviously, people who are very, very thin or lean are going to be much more of a challenge. So what I do is get my ultrasound, and I will look at the amount of subcutaneous fat that a person has, typically at the abdomen and the flank areas. And if they have less than 2 centimeters of fat, then I might think about going with an alternative approach. Now, obviously, as your liposuction skills get better and better, you'll be able to harvest a small amount from multiple areas. So that 2 centimeters is not a hard and fast rule. But when you're starting out, certainly make it easy for yourself and choose patients that have enough fat to make the harvest easy for you. In terms of harvest site, the research has shown that the abdomen or the upper gluteal and flank regions really have the highest quality of fat. Whether I use the abdomen or the gluteal area, again, really depends on where it's easiest to get the best harvest. Lots of times we'll see men come in with a very protuberant belly and they think they have all this fat in their belly. And yet when you look under ultrasound, they have 1 centimeter of subcutaneous fat. That's because all of the fat in the abdomen is visceral fat, which you cannot and should not go after. So in those cases, we'll go to the flank areas. As I said, if they're very lean, you may need to harvest from multiple sites. Also, when harvesting, you really want to stay in the upper third, the most superficial third layer of the fat. That tends to have the highest number of progenitor cells and also tends to be less inflammatory than the deeper tissue. And it's also easier to anesthetize with your tumescent fluid. In terms of treatment protocols, what I'm going to share with you is my way of doing things. Now, you can talk to 100 different regenerative medicine physicians out there, and you're going to get 100 different protocols. In that sense, it's still pretty much the Wild West out there, and nobody has really come up with a definitive protocol. What I do is what I've seen based on most of the volume of research, and it seems to work really, really well in our practice. So for osteoarthritis, you have to keep in mind that arthritis, if nothing else, is an inflammatory disease. And first thing that I like to do is quiet down the inflammation in the joint. I don't want to put a lot of these expensive and potentially fragile cells into an environment that's categorized by high inflammation. In arthritic joints, you've got tumor necrosis factor alpha, you've got interleukin 1 and 6, you've got a whole host of inflammatory cytokines, and I don't want my adipose to first have to overcome all that inflammation in the joint before it starts doing meaningful work. So what I do is a prolotherapy or prolozone treatment first, about 3 to 5 days beforehand, and this really quiets down the joint. In fact, you can go one step further and do a lavage and aspiration of the joint, and then follow that with a dextrose prolotherapy or prolozone treatment. After that, 3 to 5 days later, that's when we'll do our intelliFat treatment. Now, I combine a small amount of high concentrate PRP with my adipose injection. And I do this because there are a number of studies that show that platelets help to activate the regenerative cells within the stromal vascular tissue matrix. I don't like to put too much PRP because in some cases, such as the hip, you have a limited volume in which to put stuff. So I don't want to take away from the amount of fat that I'm putting in, but I want to add enough PRP that it's going to help activate those cells within the fat. You can also see that I don't mix the SVT and the PRP in the same syringe. I found that by doing that, it has a tendency to start to clot. So what I will do is put a few cc's of the SVT in, chase that with a little bit of PRP, a few more cc's of the SVT, and finally chase it with the remaining PRP. And it will all get mixed inside the joint. About 1 month later for OA, we will follow that with a PRP only. And I look at this as adding a little more fertilizer to the seeds of the stem cells that we sowed about a month previously. And then I don't do anything for the next 4 to 6 months and watch and see what happens. Now that's a very different protocol than what we use for soft tissue. For example, if we're treating a rotator cuff partial tear or any other soft tissue structure, we just inject the SVT directly into the defect, and then I go back and I pepper that graft by using a needle and slowly injecting a little bit of PRP into that graft to help activate it and also kind of cement it in place. There's really no need for doing a pre-treatment or a post-treatment, and we see how they do over the next 2 to 3 months. The supplies that you'll need in addition to the intelliFat kit will be an array of syringes. You can see here on my prep tray that I've got several 60 cc syringes for the tumescent infiltration. In this particular setup, we're doing a bilateral knee, so I have twice as much as what I normally would use. But typically, if I'm going to be doing one major joint, I will have 60 cc's or 120 cc's of tumescent fluid. Then I have an 11 blade scalpel, and I'll show you how we use this, an 18 gauge needle. Of course, we've got our intelliFat infiltration and harvesting cannulas and the lure-to-lure transfer, and then we have our vac lock. We've got our gauzes, and all of this is sitting on a Mayo stand on a sterile drape. And this is ready for me when I walk in the exam room. For the tumescent fluid, there are a number of different solutions or formulas out there, and we can easily share that with you. You can use lactated ringers or normal saline. You definitely want the lidocaine. We use the epinephrine, and the epinephrine is important for 2 reasons. One, by closing down the microvasculature, you reduce the amount of bruising that the patient will experience, but it also significantly diminishes the amount of blood that you will aspirate in your harvest. And the less blood you have, the less you have to wash your harvest before you can process it. And of course, as David mentioned, lidocaine is very acidic, and we want to buffer that with the sodium bicarb. Also, lidocaine burns, and by adding sodium bicarb to the lidocaine, it makes it much, much more tolerable, and in many cases, almost pain-free for the patient to perform the tumescent infiltration. For my local anesthetic to numb the skin, I use 2 parts of lidocaine with epinephrine to 1 part of sodium bicarb, or 3-to-1 ratio. And again, I add the bicarb because that reduces or eliminates the burning or the stinging that patients feel when we're anesthetizing the skin. Lastly, of course, you'll need the various needles and syringes that you'll use for your injection. We typically use between 1 and 3 cc syringes. And we do this because it reduces the positive pressure of the injection. That reduces the tendency for barotrauma to the cells, but it also makes it easier to inject a highly viscous solution through smaller needles. As I mentioned, the number 11 scalpel, 18 gauge needle, which will show you, sterile drapes to create a sterile field, your sterile prep. We use chlorhexidine rather than betadine. Chlorhexidine has a broader spectrum of antimicrobial coverage, and it takes effect within 30 seconds. Betadine doesn't reach its maximum antiseptic properties until it dries, which in most cases is 3 to 5 minutes. To close our wounds after we perform harvest, we use steri strips, and we cover that with Tegaderm. And we found that the Tegaderm works really well to prevent any leakage of any residual tumescent fluid out of the wound. And then if we're going around the abdomen, we have a large ACE bandage that we wrap around the abdomen for some compression and for patient comfort. Obviously, you need your PPE materials, and hopefully some of you have enough to keep going with your procedures. In terms of workflow and setup, I have my assistants prepare the tumescent fluid and set up the procedure tray beforehand, all using sterile technique. That way, when I walk in the room, everything's ready and I can start the procedure right away. We also have the technicians draw and prepare the PRP, or at least draw the blood at the start of the procedure. So that way, by the time I get around to doing the actual injection, the PRP is ready to go. That's if you're using PRP. Everything should be ready on a Mayo stand. You shouldn't have to go back and try to prepare everything. Once you get going, you just want to keep moving smoothly. You infiltrate the tumescent fluid, and as David mentioned, after you infiltrate the tumescent fluid, you're going to have about 15 to 20 minutes allowing that to set up. So during this time, you can actually go see another patient. So you don't have to stand there and wait for that tumescent fluid to be set up. And this enables you to be more efficient in terms of scheduling your patients. Here is, again, a broader view of the tray all set up. We've got our tumescent fluid ready to go. We've got our harvesting syringe, our infiltration and harvesting cannulas, our sterile gauze, and our instruments to enter the skin. Let's walk through this and you can see exactly what this is going to do. So we've got the tumescent fluid all ready to go. We've got the VacLock syringe, which is ready to go. We've got our infiltration and harvesting cannulas ready to go. You can see the harvesting cannula has the larger holes for aspiration. This is the 11 blade, 18 gauge by 1.5 inch or 2 inch. The syringe caps are to seal the syringe. And then we have the lure to lure transfer, and we have the gauze ready to go. The whole thing gets covered with a sterile drape until we're ready to use it. So this is the intelliFat regenerative medicine kit. As you can see, we don't have the infiltration, the injection cannulas that are used for plastics, and we don't have the dermal stamp, but we have the same infiltration, tumescent infiltration and harvesting cannulas, and we have the same filters and the same transfers. So it's basically the same kit minus the things that you don't need for plastics. In terms of the actual operative procedure, you want to determine where you're going to start the harvest and the skin with a skin marker. We clean and prep the skin using our chlorhexidine and we apply the sterile drapes. We then administer the local anesthesia. We lance the skin with an 11 blade, just the skin. I don't like to go deep into the tissue because that creates more of a wound that may have problems with bleeding later on. I use the 18 gauge needle to subsize the subcutaneous tissue, and this makes it a lot easier to close the wound afterwards. As David showed, we attach the infiltrating cannula, and then here's a key point. You insert the cannula initially perpendicular to the skin to get past the skin and subdermis. And then once you're through the skin, you assume a position that's parallel to the skin surface to perform. One really important point is not to dump the tumescent fluid all in one spot. You want to very slowly infiltrate that tumescent fluid as you fan the cannula out over the target area that you're going to be harvesting. Again, you don't want to dump it all in one location because then you're going to have areas that are not adequately anesthetized. Another thing that I see beginners use is they just go in 2 or 3 centimeters and only use a portion of the cannula. As you'll see in the video, you want to use the full length of the cannula when you're infiltrating because that enables you to use the full length of the harvesting cannula when you go to harvest. Once you've done the tumescent infiltration, we cover the wounds with sterile gauze, then we cover the entire field with a sterile drape, and we recover the procedure tray with a sterile drape, and we come back in 15 to 20 minutes. Once we start the operative procedure, we attach the harvesting cannula to the VacLock syringe. Now, it's important not to apply suction on the syringe first. You have to insert the cannula. Now, something that David didn't show and that I have found makes a big difference in improving the quality of your aspiration is we pre-tunnel the adipose for about 60 seconds. We're not aspirating. We're just going back and forth into the adipose with the harvesting cannula, and this breaks up the fibrous tissue and all of the septae in the connective tissue. Eventually, it should feel like a warm knife going through soft butter. You don't want to feel any of these fibrous bands as you're going through. Once it feels really smooth, then with the cannula remaining in the tissue, we pull the plunger back to the 10 cc mark and lock it. Don't pull back any farther because it can cause the barotrauma. We perform the harvest until we have 10 cc's, then we retract back another 10 cc's, and we keep going in 10 cc increments. Here's a video of the actual procedure. So I'm lancing the skin with the 11 blade, just enough to get through the skin. And I generally like to harvest an equal amount from both sides of the body, just in case there's any cosmetic issues. I use the 18 gauge needle to subsize the deeper tissue and make it easier for the cannula to get into the adipose layer. Now I'm infiltrating with the tumescent infiltration. You can see how slowly I'm pushing on that plunger, and I'm very slowly infiltrating both on the advance and the retraction of the cannula. Now we're about to harvest, so we've waited our 15 to 20 minutes, and you can see that all I'm doing is pre-tunneling. There's no traction on the syringe. The syringe is bottomed out, and I'm breaking up the adipose, and you can see the tissue where it's blanched, which means we got good hemostasis. So I've pulled back to 10 cc's and I've locked the syringe. And with my other hand, I'm feeling where the tip of that cannula is. And you can see I'm using the full length of the cannula, very slowly fanning left to right, really not going more than a couple of millimeters in either direction, but using the full length of the cannula. Once I have 10 cc's, I retract back another 10 cc's and perform again the full length of the cannula. With my left hand, I'm just feeling where the tip of the cannula is. And there's our 30 cc's, and you can see that's a really clean harvest. There's hardly any heme in that. So once we have our harvest, we gravity decant. Basically, you turn the syringe upside down, you've put a cap on it, and you wait about 10 minutes for the specimen to separate. The heme will be at the bottom and the fat will be at the top. We use the filters in the kit to separate them, and then we micronize and resize the fat using the diamond resizer and redistribute the final product into the injection syringes. So in this next video, you can see that the harvest has been decanted and it's separated, and you see the heme and the tumescent fluid is at the bottom. And using the blue filter, we're going to express everything up to the fat into a tray. And we actually use the top of the intelliFat tray as our waste bin. Works great. You don't need to buy another waste bin. So you push out the tumescent fluid and the heme until you encounter resistance. Basically, you're getting all of the waste fluid out, and you will be left with only the adipose harvest. We take that off and we apply a lure-to-lure transfer, and we are going to transfer 10 cc's into the syringe. Now, I'm going to pause for just a moment here because there's one step here that we did not do. Because this was such a clean harvest, meaning that there was very, very little blood in it, we did not have to wash this. So we omitted the washing step. If there's heme, a bloody harvest, then you will want to perform the washing step that was showed in the video. So I just want to point out that that's not being shown here. We're going right to the resizing because I got a very good clean harvest. So we are going to take 10 cc's of our harvest. We're going to transfer it into a 10 cc syringe. And the reason we only use 10 cc's at a time is because that's the maximum amount that you want to push through the diamond resizer at any one time. So we take 10 cc's, attach the diamond resizer, attach a clean syringe to the other side. And you can see my technician is going to push the fat up through the diamond resizer so there's no dead air in the diamond resizer. And then we pass the harvest back and forth through the diamond resizer anywhere between 10 and 20 times. If you want a thicker graft, I would do it 10 times. If you want a thinner graft, I would do it 20 times. Each pass one way is one time. So now we've processed it, we put a syringe cap on it, and now we are ready to distribute it into our syringes for the actual injection. So this is our layout for our injection tray. And you can see that everything that I need for the injection is laid out. We've got our PRP syringes here. We've got some exosomes, which we sometimes use. And then all of our adipose is been decanted into 3cc syringes in this case. This was a knee injection, so I was able to use a 3cc syringe. If I was using something smaller, like if I was injecting a CMC joint or an MTP joint, a very small joint, I would probably use a 1cc syringe. And I have a little extra fat left over just in case I felt I needed it. These are the syringes for our local skin anesthesia. And then of course we've got our sterile preps, our sterile gloves, and our needles for injection. And we have a sterile skin marker as well. And so this is the whole tray. Everything is set up, ready to go. I would inject, first I would anesthetize the tissue. I would inject a little bit of the SVT, chase it with a little bit of PRP, inject the rest of the SVT, and then inject the remainder of the PRP. So here we have 4 3cc syringes. For one knee, I would inject 3 cc's of the fat, chase it with maybe 1 cc of PRP, inject the next 3 cc's of fat, chase it with the remaining PRP, and then I would do the same thing on the opposite side in the opposite knee. So obviously, I'm a strong believer in ultrasound. When you actually see where the needle goes compared to where you think it goes, it's very humbling. Also, when patients are spending this kind of money on a procedure, you don't want there to be any doubt that the product did not go exactly where you want it to go. So I strongly recommend learning ultrasound in order to guide your needle. Fluoroscopy is okay for joints, but the problem with fluoroscopy is you cannot see tears in the soft tissue. And you could be 1 millimeter off and not be in the tear in the soft tissue. So I strongly encourage you to hone your ultrasound injection skills. In terms of injection amounts, I won't belabor this for the sake of time, but these are the amounts that I generally use in the various tissues, depending on the nature of the pathology. Other than PRP, I usually don't need anything else. There are some people who would use bone marrow aspirate instead of PRP. That's completely acceptable. It does add another significant layer of cost and a little bit morbidity. So I found the PRP works really, really well. I would not use PRP and bone marrow and adipose altogether. I think that's redundant. I would either use PRP or bone marrow with the adipose. If you choose to add another biologic agent, I have found the best results personally by using the Exoglow exosomes from Chimera Labs. These are growth factors that are extracted from culture expanded placental stem cells. I do not think that the other exosome products are as good. That's just my personal preference, but I'll leave that discussion for another day. Post-operative, we put them on prophylactic antibiotics for 5 days, and I typically use Keflex unless there's an allergic aspect to that. For post-op pain meds, most people can get by with using Tramadol, and I only give them about 3 days worth. In my experience, the vast majority of patients will have some soreness that evening, and then maybe a little bit the next day. Rarely do I have pain that lasts more than 3 days, and rarely do I have pain that requires anything stronger than Tramadol. Tylenol is okay, but I prohibit the anti-inflammatories for 1 week. In terms of the area where you perform the harvest, there's no showering for 24 hours. And I want them to avoid any immersion in water for 3 days. So that means no bath, no swimming, no hot tub for 3 days. I want the wound to close completely before they get into the water. Okay. Post-op activity restrictions. For osteoarthritis, we actually allow full weight bearing right away, but I limit their impact activities. So that's running, jumping, racquetball, tennis, any impact activities for 90 days. If we're treating a meniscus or a hip labrum, I put them on crutches for 1 week and then weight bearing to tolerance after that for another week, and then continued no impact for 90 days. I also want them to avoid any activities that are putting a tremendous amount of pressure on the joint, because I don't want that labrum to get disrupted by things such as squats, lunges, leg presses, and so on. If we're treating a shoulder labrum or a rotator cuff, I typically put them in a sling for a week, come out periodically during that week just for some pendulum range of motion exercises. I also don't want them doing any shoulder level or overhead activity for at least 6 weeks, and no weight training that's, resistance training that involves the shoulder for 3 months. And that's really hard for some patients, but you really want that graft to set up in those cuffs and in those labrums and not get disrupted by returning to weight training. You can have them begin physical therapy at 3 weeks, but they have to avoid high load strength training at that point. So that pretty much wraps up my portion of the clinical aspects of it. I really appreciate your taking the time to listen to our presentation. And David, I don't know if you have any other final comments. I can be easily reached by my email, and I encourage people to contact me with any questions at all about the clinical aspects of the intelliFat system.
Thanks, Dr. Paul. That was absolutely wonderful. Really appreciate you taking the time to share your experience and expertise with us.